So good morning, everybody. So today we will be discussing on the dislocation and the subluxation of the joint. So we shall be discussing on the subluxation of the joint. So in orthopedics, in day-to-day practice, or you see the case in outpatient department or the emergency department, dislocation or the subluxation of the joint is one of the entity that sincere one.
Paused watch.
So are you getting the screen now?
Fine, sir. Slide.
Hello.
Sir.
So are you getting the screen now?
No, sir.
Not it, sir.
स्क्रीन पॉज भए छ के पुरै
गर्नु पर्ला जस्तो छ सर फेरि
अब देखिरहेछ So are you getting the screen now?
Sir, yes, sir. Now.
Yes, sir.
So the dislocation and the subluxation are those entities, those should be approached without any delay or without any of the. So starting with the definition, the dislocation are those things are defined as when the articular surfaces of the joint are completely displaced one from the other, so that the contact between them is almost lost. Whereas subluxation is the condition where when the articular surfaces are only partially displaced and they retain some contact in between them. So in these two figures, there are two diagrams. Where what you can see is, so this is a dislocation, and this is a knee dislocation, posterior knee dislocation, and this is the case of an ankle sub. So both of these are the dire emergency in the orthopedic. So starting with how the dislocation or the subluxation do occur, the the factors responsible for the stability of a joint. So why do the joint dislocate? There are certain factors that are responsible for maintaining the uh, integrity of a joint. First becomes the shape of a joint. The second becomes the ligament, which is also known as static stabilizers. Muscles are the dynamic stabilizers. So starting with the shape of a joint. So if you compare a stability of a hip joint with a joint, so what you can see in a hip joint is the socket is deep over there. The stabular socket is deep, so the femoral head can easily move around over there. So on the same scenario, if you compare it with the shoulder joint, what we have is the glenoid fossa is a shallow joint, shallow surface. It makes a shallow. So and the humeral head rotates over there. So in these circumstances, the shallowness of the joint or the shallowness of the moving part of the joint causes the instability. Secondly comes the ligaments. There are a lot of ligaments around the joint. If you compare with the ankle, you see the fibular ligament, interosseous membrane, so deltoid ligament. They're all the ligaments you see. So they all what they do is they provide all the static states. They act all of them act as static stabilizers. So on the same circumstance, we have a lot of muscles around the joint, or the one with the bulky muscles around. They all of them act as a dynamic stabilizers. So I'm going to the classification of joint dislocation or subluxation. So either they can be congenital or they can be acquired. So if they are congenital, or in a case scenario of acquired joint dislocation, you can have a pathological or a traumatic dislocation. So the congenital dislocation remarks to the congenital dislocation of hip or deltoid dysplasia of hip. You can also say that DDS or CDS in whatever means you say. So the next becomes the pathological dislocation. So there are a lot of conditions like as polio, like as infection, usually the septic arthritis or the osteomyelitis in the metaphyseal region of the infants usually. So these causes the joint subluxation dislocation. So these are the pathological conditions. The few pathological conditions we encountered. The infection is one of the very high cause. Is a very common condition that usually causes the joint subluxation or dislocation. The next one is a case of a traumatic. This is the most commoner one. There is a tearing of the ligaments. There is a tearing of a muscles. There is tearing of a capsule. So this results to joint subluxation or either the dislocation. So what happens when there is joint subluxation or dislocation? Whenever there is a dislocation, it must damage or it must injure a layer of a capsule, a joint capsule. Sometimes the capsule is not torn in its substance, but is stripped from only of its attachments. So, so what happens is sometimes the capsule is not torn. Rather, what happens is so the capsule is attached to one of the bony circumstances or the bony attachments uh, enclosing the joint. So what happens is the capsule is detached from those of the bony attachments. Sometimes it can occur, or rarely, a ligament may withstand the force of injury so that instead of a ligament rupture, so there is the avulsion of a ligament. So this scenario you see in a case of a ankle injury, or sometimes in ankle subluxation, what we see is there is a partial avulsion of a fibular portion or some part of a talus. So there is a area of a ligament which gets avulsed on the or chipped off, or at the time of dislocation, a piece of articular cartilage, with or without its underlying bone, may be shaved off. This is another certain occur in the subluxation or the process of a dislocation. There is a piece of articular cartilage that gets avulsed, that comes in between the two contacts of the two surfaces of the bones, and it produces the further symptoms like this knee locking or which of the symptoms you can see. So these are just the osteochondral fragment you can see. So there are various dislocation and subluxation in our body. Starting from the upper limb, we can have a shoulder dislocation, we can have an elbow dislocation, there can be a wrist dislocation as well, there can be the base of first index finger dislocation, thumb dislocation. So these are various dislocations on coming to the knee foot. The commoner ones are hip dislocation, knee dislocation, ankle dislocation, and there is a list sprain and psoas dislocation as well. So there are a lot of various dislocations. There can be dislocation of the spine, cervical spine, usually over the C67 region or the thoracolumbar junction. So whenever you see a dislocation, there are a lot of various dislocations. So on this class, so we have limited time, so we're just discussing over the few common of upper limb and one of our lower limb in a very brief way. So starting with the hip dislocation. So hip dislocation is of three types. It is of a posterior dislocation, anterior dislocation, or the central fracture dislocation. So among these three, the posterior dislocation is the commonest variety. So what happens in posterior dislocation is the head of the femur is pushed out of the sternum posteriorly. In about 50% of the cases, this is associated with the chip fracture of the posterior lip of the sternum, in which case it is also called as a fracture dislocation. So what happens in the mechanism of injury is usually there is a motor vehicle accident. So it's a very high velocity injury. There is a high velocity injury or the motor vehicle accident. Or you can say it's a dashboard injury. What happens in dashboard injury is this female is driving her car. So she had to apply a brake very sudden on a very sudden circumstances. So what happens is of a car, her knee gets stuck to the dashboard or they collide with each other and the force is directed over here and the dislocation of the hip occurs. So it's also known as a dashboard injury. So posterior hip dislocation is one of the mechanisms of injury is a dashboard injury. So other injuries that can occur in this other associated injuries that can occur there can be a patellar fracture, there can be the lower femoral fracture, or sometimes there can be a very rare circumstance there can be knee dislocation as well. So the patient come to the emergency department, you attend her, what you will see? So this is the typical clinical picture you will encounter if you see a patient of a posterior hip dislocation lying on a bed crouch or examination crouch in the emergency department. So it's very easy to diagnose. There is a history of a severe trauma followed by pain, swelling, and deformity. So the deformity is very much marked. So you have to know the deformity. So what could the deformities are? The deformity could be leg adduction and the internal rotation. So in a meantime, you have to. So these three things, these deformity are very commonly asked in exam. So basically in MCQ, so you have to know these three deformities, and there is associated sorting of a leg. And if you after just evaluating the patient, after just seeing the LCD of a limb, so in this case, there is a flexion of a hip, there is a flexion of a hip, there is adduction as well. There is no abduction, there is adduction, and 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 there is internal rotation. So look, the patella is facing inwards. So this is the internal rotation. So if you go to the bedside of a patient and you palpate it over there, you can palpate the head of femur over the gluteal region. So sometimes what happens is if these things do concurrently occur with the fracture shaft of femur, so these things are going to be missed. So you have to evaluate with the edge of a limb. You have to check it. You have to palpate it over there. So you clinically evaluate the patient. You send the patient for the investigations. You can send CT X-ray or X-ray, CT scan, or even MRI as well. But MRI in a case of acute hip dislocation is not much of a significance. Though on the rare circumstance it can be used, but on the acute conditions it is not of much help. So starting with the X-ray, you see the femoral head is out of a stabulum. So this is the normal side. So the head is inside the stabulum, but in this case the head is outside the stabulum. The thigh is internal rotated, and if the thigh is internal rotated, the lesser trochanter is not seen. So the lesser trochanter is not seen on this X-ray. And the sentence line is broken. So coming to the sentence line is just an imaginary line. So if you draw an imaginary line from the medial cortex, the medial part of a neck, starting from the neck and continuing to the inferior border of the superior pubic rami. So this is the sentence line. This is the sentence line. So this is a sentence line. So coming to the side, the sentence line is broken. The head is in front of the eye is internal rotated. The femoral head is out of acetabulum, and there is a bony chip from the posterior lip of acetabulum. So if you check it over here, so this is the anterior lip, and this is the posterior lip of acetabulum. If you check it over here, you can find a bony chip or just a fracture or a revulsion fracture from the posterior lip of acetabulum, or a portion from the head. So CT scan is always necessary whenever you suspect a fracture case of a fracture dislocation. You send a patient with the CT scan. You send the patient for a CT scan. So coming to the anterior dislocation, femoral head is situated anterior to the acetabulum. The mode of injury is in this anterior dislocation is usually a hyperextension force against an abducted leg. The leg is abducted. The leg is abducted, and there is an and the is you see in a normal position or the extension, the hyperextension force acts over there and levers the head out of the acetabulum anteriorly. So the clinical feature you will see is there is a minimal flexion or sometimes extension as well. The limb is external rotated. It's markedly abducted. So if you see the left limb of this patient lying on a bed couch, you can see it's minimally flexed. Sometimes there can be extension as well. It is external rotated. It's from the fertilized slightly pushing outward. It's markedly abducted. There is no adduction. There is abduction. So and there is the apparent lengthening as well. So anterior knee dislocation, there can be a extension, external rotation, and the abduction. So these deformities are, I repeat again, these deformities are very important for an MCQ point of view. So how will you manage the hip dislocation? So reduction is an emergency process. So most cases possible to reduce the hip by manipulation under general anesthesia. The chief fracture of the acetabulum, if present, or chief fracture of the head, femoral head, if present, usually falls in place if the head is reduced itself. Sometimes, however, sometimes we may require the open reduction. So the indications for open reduction can be if the closed reduction fails, or there is a presence of an intra-articular loose fragment or the osteochondral fragment preventing the accurate reduction. If the acetabular fragment is large enough and is from the weight-bearing portion of the acetabulum. So these are the few indications that you will have to evaluate if you are going for open reduction after the failure of a closed reduction. So there are varieties of ways, there are various ways of closed reduction. One can be a Ellis method, the other can be Stimson gravity method, is Baltimore technique, Bigelow maneuver, and the Captain Morgan technique. So you don't have to know much more about each of the process, but you take a brief look over the few of these photographs. So this is the Ellis method. The assistant applies the counter traction over the pelvis. So this is the counter traction, and the first version, the first one applies a traction along the line of a deformity, the first one, and then he gradually rotate the limb. He tries to do the external rotation. The limb is internal rotation. He tries to do the external rotation. This is the external rotation, and then what he does is he's pulling upwards. He's rotating the limb, and on sudden clunk of a movement or a clunk of if the clunk sound is heard, if there is a sudden torque of movement, hip gets reduced and then it is extended and gradually in sudden degree of abduction, abducted position. So this is a Bigelow method. Similar to Ellis, the assistant applies you the counter traction and the surgeon applies the traction of the limb along the line of deformity. But what he does in Ellis method, what we do is we do the external rotation But in this case, what the one does is it does the internal as well as external rotation along the and once the head is pulled out of the sternum, so in this term, after you pull it enough, you apply the internal and external rotation, and then you finally after the reduction, you keep the limb in extended and appropriate position. So this is is Baltimore lift. So in the earlier methods, we just have to use two individuals, or we need to have two individuals for performing the method. But in this process, the East Baltimore lift, we need three surgeons. So what he does is, so we just make a fulcrum over the knee, and we manipulate the femoral head, and we try to do the reduction. The other one is Stimson gravity method. So what happens is he gives a counter traction, and the surgeon applies the traction over here, and it's manipulated. That will manipulate. So this way, with the aid of gravity, we can reduce the dislocated femoral head. So this is one in the Stimson gravity method. So other one is the Captain Morgan technique. So you have a lot of you have seen the Captain Morgan picture. So this is a common picture we see of the Captain Morgan. So similar method like this Baltimore lift. So what we do in this method is, so in this Baltimore lift, you make one of your resistance hand as a fulcrum, putting it, making you put it over your shoulder. So on this term, we use our own limb, our own thigh as a fulcrum. And this is the first hand we apply over the thigh, and the next hand we apply over the ankle for the rotation part, and then we make a fulcrum, and then we reduce the dislocation. So coming to the second dislocation, the other common dislocation we encounter in the upper limb. So the shoulder is the most unstable large limb. So I have discussed earlier, live in anatomy. So with the mobility, with the expense of mobility, the shoulder has less stability. The glenoid fossa of the shoulder joint is very much shallow, and the rotating humeral head over the glenoid fossa has a very high chance of a dislocation. Once there is a unexpected severe forces act against the resisting or stabilizing forces or the ligaments or the muscles around the joint. So the reasons for the instability there can be a shallow glenoid. The first thing, the extraordinary range of motion. The shoulder has a very high range of motion, unrestricted range of motion. The other one is the vulnerability. There is upper limbs are always vulnerable to the injury. If a patient sustains a traffic accident or the motor vehicle accident, there is high chance that there is an injury to the upper limb more than that of the lower limb. Or there can be some other underlying conditions like the ligamentous laxity. Patients with the ligamentous laxity can have a shoulder dislocation, but those are the habitual dislocators. So coming to the classification, so the most common in hip was a posterior dislocation, but coming to the shoulder, it is anterior dislocation again. So there is one way of memorizing the commoner dislocations over upper limb and the lower limb. So what we can do is the shoulder is the commoner one is the anterior dislocation. Whenever it comes posterior dislocation, and over the wrist it again becomes anterior. So it becomes anterior, posterior, and anterior again. So when it comes to the lower limb, if you have to memorize it in a certain way, the hip has a posterior dislocation. The commoner one of knee is the anterior dislocation, and the ankle is a posterior dislocation. So starting with the classification of the anterior dislocation, the anterior dislocation can be subglenoid, just beneath the glenoid, subclavicular, or intrathoracic. The posterior dislocation, very rare one, easily found in the recurrent dislocation cases. It can be subacromial, subglenoid, or subspinous. Or the other one is the inferior dislocation or obturator recta is a rare complication, is a rare variety, is a one very rare variety, less than even 1% it is said in the literature. So coming to the clinical features of a dislocation. starting with the anterior shoulder dislocation, there is a history of indirect fall on abductor and the extended shoulder or the direct blow on the shoulder from the behind. So there can be the limb is abducted, extended, and and the patient falls. So this force acts always over here, the force transmits over here, and there's a high chance that shoulder can get dislocated anteriorly. Or there can be a direct blow on the shoulder from the behind. If there is any sort of a direct blow from the behind, there's a chance that the shoulder is dislocated anteriorly. So the patient will have, of course, the pain and the difficulty in movement. So how the patient will come to you, either in outpatient department or the emergency department, is he holds the injured limb with the other hand close to the trunk. The shoulder is abducted and the elbow is flexed. So in the anterior dislocation, the one thing we have to always see is whether or not the shoulder is abducted or not. So if you again go nearby to the patient and see and try to examine him or her, then what you can see is you have the contour of the shoulder is lost. So this much contour of the shoulder is lost. On the side, the contour of the shoulder is lost over. It's more clear over here. The contour of the shoulder is lost. It's appears it's stable. The and if there is severe dislocation or you see the subglenoid form or the intrathoracic form, you can see the visible humeral head just over the chest region, over this part. But if you palpate it open, of course you can of course palpate the humeral head, and there is the impliglenoid socket. These are the few clinical features you see as symptoms or you see on evaluating the patient. So coming to the posterior shoulder dislocation, there is a history of a seizure. Usually the patient gives you the history of a fall on legs and the adducted arm, adducted limb. Or there can be the direct blow anteriorly. Limb is adducted and internally rotated. The patient comes with the limb adducted and internally rotated. So coming to the investigations, you can say in X-rays, you can say X-ray of a shoulder AP view, you can say in CT scan, even the MRI. So MRI has some significance in actual location or some sort of recurrent shoulder dislocation. If you say, so X-ray is the common form. You can say the shoulder anterior posterior view, lateral view, Y view. So this is a case of anterior shoulder dislocation. It's a subglenoid variety. The shoulder is just coming anteriorly. And this is a case of a posterior shoulder dislocation. What you see in a posterior shoulder dislocation is the humeral head appears much larger and it attains the shape similar to that of a bulb. Or we can also say there is the bulb sign is present in the case of a posterior shoulder dislocation whenever you do an X-ray shoulder anterior posterior view. So if you suspect that there can be some exterior fracture, you can send patient for CT scan. And if the patient is a habitual or if there is a case of a recurrent shoulder dislocation, you have to send a patient for MRI. So what you can find in MRI is there are few soft tissue lesions. So one of them, this is the Bankart's lesion. So Bankart's lesion is a lesion over the labrum of the glenoid fossa. So what happens is it occurs, the Bankart lesion occurs in the lower part of the labrum. So this is the lower part of the labrum, what you see. So this is a normal labrum. This is a glenoid fossa. This is a labrum. This is a labrum. This is a labrum. All of this is the labrum. So this part you see over here, this part is labrum. So there is a chance that in a case of pancreas in the lower part of labrum, it gets injured. So there are varieties of pancreas lesion, or there can be variety of labral injuries. So you don't have no need to know much about those things. The other injury that you can find in the MRI shoulder, if you suspect and send the patient for, is the Ilsac's lesion. The Ilsac's is nothing more. It's just a posterior lateral head defect. So in a case of a traumatic anterior shoulder dislocation, what you see is there is a labral detachment associated with the posterior lateral head defect. So Bankhart's lesion is of the glenoid fossa, and Hill-Sachs lesion is always of the humeral head. We have to know these two things. So coming to the management, the emergency. So it's an orthopedic emergency. Should be reduced within 24 hours, or else there is a high chance there can be the AVN of a head of a humerus. So it is immobilized and stripped to the trunk for 3 to 4 weeks and rested in collar, and nothing has changed recently. So the recent literature says about the immobilization should be kept to minimal, usually 2 weeks or so, not more than 2 weeks. It's often said. So how we can reduce this practice? We can go for reduction. They can be closed or open. So there are a lot of maneuvers you can do. They can be contraction method, Hippocrates method, Stinson's technique, and the coach's technique. So this is a traction contraction technique. The resident applies a contraction and you apply a traction over here on the line of deformity, and it will usually get relocated easily. So this is the exact method of traction contraction. The other one is the Hippocrates method. So it's the old one. It's of a historical significance only. So what it does is the resistant applies the counter traction. And what you do is you put your foot limb over the axilla as a part of a fulcrum, and you give a traction along the line of deformity. So this is a typical Hippocrates method. So this method has been abandoned now due to a lot of complications we encountered while pressing it over the axilla. The other one is tension gravity technique. You ask the patient to lie down prone, and you don't ask the patient to hold the weight. So you just what you do is you tie up something, some weight into the patient's wrist, and just ask him to swing it. Just keep his limb in this position, uh, and after a few times the head gets dislocated easily. The other one is the coach's technique. So the coach's technique is just a traction. You apply your traction as well as the contraction. Then starting with that, you apply there is the external rotation. You do the external rotation, then adduction, and then internal rotation finally. So whichever formula you go by, either you go by the formula T E A I T I, or you can go with the formula T. So you do the flexion. The flexed elbow is the traction is applied to the flexed elbow. It stands for T traction. E stands for the external rotation. You gradually external rotate the limb. The third part is you after you do the external rotation and traction, the head gets relocated. Then you gradually adduct the limb, and finally, what you do is you internal rotate the limb. So this is a teammate. So there can be a lot of complications when you are dealing with the dislocation or the subluxation. You have to come across these complications in your mind whenever you are dealing with things. So the immediate complication can be injury to the neurovascular bundle of the limb. So there can be injury to the axillary nerve in a case of a shoulder. There can be injury to the sciatic nerve over the hip. There can be injury to the popliteal artery over the knee. So the injury to the popliteal artery is very much devastating, and about 90% of cases often land up in the erroneous amputation. The early complications can be there can be a recurrence, like is in the case of the shoulder. So shoulder is the completely have a recurrent shoulder dislocation. There can be a myositis of significance. There can be a persistent instability if not surgically treated, unless surgically treated or something like that. There can be a joint stiffness. The resultant if there is a joint dislocation and you keep the patient in an immobilized position for a very long duration, it can often lead into the joint stiffness. And coming to the late complication, you can have a recurrence. The other one is you can have the similar one to the early complications. The other one is the osteoarthritis. You see, and the other one, the final one is the avascular necrosis. The avascular necrosis is the much commoner complications you encounter in a case either of a femoral head or in a case of a limb or in a case of a shoulder. So the femoral head can get avascularized. So there can be other avascular necrosis of the humeral head. So finally, take home message is dislocations are the true emergency in orthopedics. So dislocations, whenever you approach, should be attempted for reduction under suitable anesthesia. So dislocation, when not approached early enough, can lead to the limb-threatening conditions like 90% of the knee dislocations usually land up at above knee amputation or the knee disarticulation. So whenever you be a house officer at the Department of Emergency, one thing you have to know is the dislocations are the true and the serious orthopedic emergency that you have to. Okay, thank you for today.
कौन सा लीव बता